Good morning, and thank you for joining us today for our fourth Community of Practice Lunch and Learn webinar. My name is Becca Newman, and I am a project coordinator at the Center for Behavioral Health and Justice, a community-based research center that provides local communities, organizations, and behavioral health and law enforcement agencies across Michigan with technical assistance, evaluation, and support to optimize diversion of individuals from jail and prison through the implementation of best and innovative practices at every intercept of the criminal justice continuum. This webinar is part of our Opioid Treatment Ecosystem Initiative, OTE, which is a technical assistance framework aimed at strengthening community-based substance use disorder treatment at the intersection of criminal legal systems. Through this framework, the CBHJ has convened county-level change teams that feed into the larger community of practice, including all of you who have joined us here today. Collectively, this community of practice is working to provide life-saving medications for opioid use disorder in jails, ensure continuity of care to prevent overdose upon release from jail, and connect first responder and behavioral health systems to increase community-based treatment access. Today's event, and those we hold in the future, will be focused on sharing new ideas, addressing common barriers, and allowing for discussion to encourage expansion, enhancement, and sustainability of county-level treatment ecosystems. Generous support from the Michigan Health Endowment Fund has made it possible for us to offer this event as part of the OTE community of practice. Before we get started, we have a few housekeeping items. Audio-visual capabilities have been turned off for attendees to limit distractions throughout the presentation, but we encourage you to ask questions of the presenter. You may enter your question in the Q&A box on your screen at any time. We will address questions as time permits during the roundtable discussion portion of the event. If you are calling from a phone, please press *9 to raise your hand and ask your question. Today we have Dr. Kapenga presenting for us. Dr. Kapenga is a retired anesthesiologist with credentialing in addiction medicine. She is an addictionologist engaged in full-service private practice, specializing in patients enrolled in specialty treatment courts, jail programming, and expansion of MAT in residential housing. In addition, she is a consultant for MDHHS and appointed to the Michigan Opioid Task Force Judiciary Advisory Work Group, as well as multiple other committees and planning bodies. We are grateful and excited to have her join us today with her wealth of knowledge as she presents information regarding buprenorphine to our ecosystem partners. Next slide, please.
Good morning, everyone. Hello, and thanks for joining us today. I am happy to be here. I'd like to thank everyone, Dean Kubiak, Brad, Matt, Aaliyah, Becca, and the whole crew for inviting me to do this. I won't make any jokes about snow today because we all know how much it's affected our daily lives. Although yesterday I did have a clinic with 15 buprenorphine patients. 12 of them made it in by 8:30 in the morning. One had a daughter in the hospital. One didn't get out of bed, but one got out of bed and couldn't get out of his driveway. So it can be a very motivated population as on the outside. Today's presentation is not so much medically oriented about the drug and pharmacology of MAT, but it's addressing more of the behavioral changes that we're looking at in addressing how to implement MAT and specifically buprenorphine into the judicial criminal justice system. What we'd like to do is focus on a brief overview at the first, and then towards the end of the presentation look at some of the criteria that are going to be necessary to address when you're implementing or maintaining MAT, and again, specifically focusing on buprenorphine. Next slide, please. The reference I'm using today is called the Use of Medication-Assisted Treatment for Opioid Use Disorder in Criminal Justice Settings. It's a SAMHSA presentation. You can download it. It's maybe 150 pages or so, but it's current and it is an evidence-based resource guide. Another good one that's available is Jail-Based Medication-Assisted Treatment, which is from the National Sheriff's Association. And we will have links available for some of this information should people want it. In your chat room, let us know that you want these links. Next slide, please. Buprenorphine is been around for a long time, 65. Methadone came in just around that time as well, but methadone was implemented in the United States in the 60s. Buprenorphine was finally approved for use here in 1981. As the opioid epidemic progressed, the year 2000 was critical because we finally were starting to see the opioid epidemic and the value of MAT at that point. In 2000, the Data 2000 waiver was implemented, and it's a federal act that allows providers to attend an 8-hour training course, pass a test, and then become ex-waivered in order to prescribe buprenorphine, which is a controlled substance. This year in January, that waiver was lessened so that physicians did not have to take that 8-hour course, but could provide prescriptions for buprenorphine for up to 30 patients within their state of licensure. So they're trying to get more providers out there and removing an obstacle to getting buprenorphine out into the public. With the X waiver, you were limited to 30 patients your first year, up to 100 patients your second year, and up to 275 patients your third year of practice. So there are limitations in how it was initially rolled out, but we're looking at both the state and federal levels removing those obstacles so it becomes more easily available. One of the criteria that we lifted in December of 2019 was removing the PA, the prior authorization for buprenorphine at MDHHS as an example. Next slide, please. Basically, we have three major classes of MAT medications. Buprenorphine, which is a partial agonist, and it's safer to use than methadone, and it's because of the partial activity, it causes less respiratory depression and less chance for overdose. Methadone is a full agonist for opioid receptors, and then naltrexone is a full antagonist for opioid receptors. So they all act in different manners. For buprenorphine, its major value is in decreasing cravings and symptoms of withdrawal. Methadone does the same, prevents withdrawal and decreases cravings. Naltrexone, though, only is effective in decreasing cravings because it's a full antagonist. Next slide, please. There's different formulations for buprenorphine with naloxone or as a single agent. And here are some of the names of the different brands that are with naloxone. Suboxone is a major one. Zubsolv is probably secondarily most popular. Bunavail. And then Sublocade is the injectable 28-day form of Suboxone. The single agent is Subutex, and it's a tablet. It does not have naloxone in it, and previously we used it mostly for women who were pregnant, but now any of these formulations are being used for all populations. Next slide, please. The importance of looking at MAT is that in combination with counseling, it is very effective for increasing abstinence and allowing a healthier recovery. Remember, MAT decreases cravings and the physiological withdrawal, but in order to really achieve a healthy recovery, one would need to implement the lifestyle changes which are achieved through counseling, group classes, and such, in order to learn how to deal with life on life's terms and not just turn to illicits in order to cope with life. So it's a combination approach that is evidence-based to work. By decreasing the cravings and preventing withdrawal, it does allow the patient to focus on participating in counseling. So they're not being driven crazy all day with their cravings and withdrawal. They can go to their counseling, they can go to their community meetings and learn without being distracted by the withdrawal and cravings. Next slide, please. Heroin and other illicits and alcohol as well are drugs that interrupt normal brain chemistry. All of our decision making in our brain are neurochemistry reactions, and what we want to do overall is get patients back to a normal brain chemistry without the effects of these illicit drugs and alcohol. When people are on heroin, illicits, alcohol, for a period of time, it actually causes specifically damaging changes in the physical cellular transference for making these decisions. And what we want to do over time is to stop the damage that's being caused by heroin, illicits, and alcohol, so that the normal brain chemistry can return on its own. That process alone of returning to normal brain chemistry may take 18 to 24 months, and there's nothing we can do to speed it up. Once we have those brain changes, if, for example, someone's on heroin for 1 to 2 grams a day for 7 to 10 years, they may actually have permanent brain damage that may not be reversible through abstinence. And that means they won't be making dopamine. They will continue to have cravings and withdrawal symptoms if they do not get opioids. Next slide, please. There are some very simple benefits for MAT. Not only are patients receiving pharmaceutical grade medications now, so that they know what they're getting rather than the illicits, which have so many contaminants these days. It's very dangerous. But you also have physician monitoring, as well as from the criminal justice system, you have decrease in illicit activity. With, next slide, please. It's not possible just to stop medication or to stop heroin or other illicits or alcohol. Remember, over a period of time of abuse, dependence occurs, and that's due to the physical changes in the chemical pathways. So when they discontinue these drugs, they are left with these damaged chemical pathways in their brains, and cravings and withdrawal will become their main focus throughout the day. Remember, when people first start on opioids, they are following it for the euphoria that they receive. But as you follow them over time, they tend to continue to use, not for the euphoria, they've lost that, but to prevent withdrawal symptoms. So there's a distinct change in why they're seeking heroin or other opioids over a period of time. It's not magic. This is all proven science, and we can go into that. I can give you references for that, and that's not the specific focus for today. Next slide, please. This is a pretty busy slide, but I just want to point out a couple of interesting statistics. This is current availability, and it's from 2017, 2018, which is as current as we can get. Some of the statistics are blended if MAT or Suboxone is being maintained in drug courts and jails versus initiating treatment with it. So, but the general overall picture is pretty significant here. In 2011, Maryland was #1 jail had a county that was #1 jail to offer MAT for the first time to non-pregnant inmates. In January of 2018, there were 20 states without MAT in their correctional systems, including jails and prisons, which means they would stop MAT if inmates were on them. Of several thousand jails, somewhere in the neighborhood of 2,200, only 200 of them were offering MAT in 2018, and most of that was naltrexone. At that time, only 30 jails offered methadone or buprenorphine maintenance in 14 states. So it's out there, but it should be more widely available, and we'll go into some of the reasons as we go through the presentation here. In drug courts in 2017, 50% of drug courts required patients on MAT to discontinue their methadone or buprenorphine within 30 days, which isn't appropriate. And then upon reentry or community corrections, the 10 to 40 times higher risk of death is a significant statistic because it's the #1 cause of overdose death for inmates recently discharged, because they've been in jail or prison and are abstinent when they get out within the first 2 weeks. Without MAT and full community support, their first drug use would be very dangerous because their body is not used to it, and the overdose death rate in that first 2 weeks following discharge is significant. Next slide, please. So here we have a brief timeline in 2017. It is a public health emergency. We're now over 2 million affected, and it's getting even higher. Are significance during the pandemic. In 2020, they estimated a 30% increase in overdose death rates, and then from May to now, they have actually measured another 30% increase. So there's a significant increase year by year. Overdose death rates increased 600% in the past nearly 20 years. To review, it was a prescription opioid epidemic that once the prescriptions were limited, people went to the streets for heroin, and now it's transferred over to the synthetics, meaning fentanyl, carfentanil, the designer forms of it, which are highly concentrated, 100 times more potent than morphine, and people can easily overdose because of the small amounts that are needed. Another emerging trend right now, as everyone knows, is the meth epidemic, and that's a separate talk, but again, the synthetics are taking over. Not only are we seeing a significant amount of meth, but we're seeing a significant amount of contaminants in heroin, and the #1 contaminant is fentanyl. Normally, we would see maybe heroin with cocaine, maybe benzo stuck in there. Now we're seeing 5 different drug classes, and in one of the clinics, I've seen 3 patients now coming in with 10 different drug classes in their urine. When they're asking their dealer for heroin, they think they're getting heroin, but they're getting 9 other contaminants. And quite frankly, they're walking around looking sort of normal and functioning, but when you get their urine, it shows a really lethal combination, and they're at high risk for overdose without proper monitoring and maintenance. In 2016, the National Survey for Drug Use and Health Survey had some statistics here. The interesting one is if you're a non-user, 16% are prone to be involved in the criminal justice system. If you're abusing prescription opioids, it increases to 50% involvement in criminal justice system. And if you're on heroin, it's nearly 80% will at some point be involved in the criminal justice system. Next slide, please. Why isn't MAT universally embraced? And part of this, this is going to be the discussion point, but part of this is an emerging and changing horizon right now, because addiction is a medical disease, and just like we would not withhold insulin from a person with diabetes, why are we still continuing to question implementing MAT and treating addiction? There's regional differences. The east side of the United States tends to be more lenient and more progressive in implementing it. The east side of Michigan tends to be more open about implementing it. Federal funding now requires offering MAT in the programs that are receiving federal funding. It's best practices from ASAM and SAMHSA through evidence-based programming. We are seeing changing attitudes towards treating drug addiction, and one of them I've noticed is that in talking with people over time, I deal with patients, families, and agencies. People tend to change or pay attention to changing their attitudes towards it once they're personally affected, either a personal journey with addiction or a loved one's journey or a client's journey, for example. So that personal connection is really powerful for bringing the message home, how bad a disease addiction is. And yes, we should be using every available tool that we have in order to treat it. One of the judges that I work with, and I do work with multiple courts and several jails, one of the judges, when I asked her, you know, what is it from your peer-to-peer interactions that some of the judges and sheriffs are not supportive automatically for MAT? And this is her response, that it's not a question about their beliefs about MAT. It boils down to being the right of the patient to have medical care through the national acts. Are they willing to experience litigation from the ACLU? And we have seen multiple cases throughout the United States, and the ACLU is pretty active in Michigan and is looking at several jail systems here. So it's interesting to note that she said that. So to keep it in the mix for the discussion, how do we address these personal beliefs of the people that are in authority for implementing or denying MAT? Next slide, please. Compliance. In 2011, the NADCP Board of Directors passed several resolutions in support of MAT for best practice standards. So these are the drug treatment court programming at the national level is supported 10 years ago. In 2015, the courts receiving federal grant funding either through the BJA or SAMHSA must allow access for those eligible to MAT. Next slide, please. These state reports are kind of interesting. There's more detailed in the SAMHSA publication that I'm using as a reference, but from a practical standpoint, New Jersey, showed, and this is just a couple years ago, 90% of their inmates completed the MAT program, which is significant. In my private practice, I probably see a 60 to 70% continuity. There's a huge drop off after about 2 to 3 to 4 months because people are seeing how much work it is to do recovery and to receive these medications. So for 90% of inmates to complete an MAT program is significant. In Rhode Island, they reduced their overdose death rates at discharge by 50%. In Kentucky, from a financial standpoint, for every dollar spent, there's a $5 return, and it may not be specifically at that jail, but a return somewhere in the criminal justice system where they're saving a lot of money there. And 70% of the inmates that received MAT were employed at 1 year after discharge. Next slide, please. Why is it so difficult to incorporate MAT in the jails and treatment court system? The treatment courts are accountable in Michigan to the SCAO, and the jails are not. There's a diaphanous kind of structure because jails are county level. There's no real state oversight for them to follow. Each jail kind of does its own thing, and each sheriff can do kind of their own thing. So that's one of the problems that we're having in getting a complete compliance program for the jail system through the state. Why is it so difficult? Lack of information. You know, there's a lot of science here. This is medicine. It's not just criminal justice. You break the law, you go to jail. It's not a check box. It's a very individualized understanding of why that person's doing drugs, what do they need for a recovery program, and then what's going to work for them within the confines of their resources. So misunderstanding, lack of information. Everybody should do all they can to learn as much as they can and to keep current. There is so much going on right now and updating in order to understand this disease. Current policies do not support MAT. Yeah, it's going to be a lot of work to get them in compliance with current standards. No trained providers. This has been a pretty challenging field over the past several years. Not only is there no minimal state support for overall financing for treatment programs, the lack of federal level organization has also created problems. This is not an attractive field for physicians to go into. The payments are less than adequate. The patients can be very challenging, abusive, disruptive in an office setting, can be very time consuming. And those are patients that are not in the criminal justice system. For some of them that are in the criminal justice system, drug courts and jails that I've worked with, they are incredibly time consuming, especially at the beginning. Many providers are not comfortable with dealing with the criminogenic thinking and don't want them in their offices with their other patients. They're feeling threatened. So getting provider access is a huge problem right now, especially during the pandemic. I understand the number of physicians overall in Michigan has decreased significantly as they've retired or left the field. And that is going to be really detrimental in finding adequate and providers with expertise for the criminogenic population. Detox services are available, but if you don't have direct discharge from a detox program to a maintenance program or to sober living after the detox, that disconnect there is a huge point for people to relapse during that time. Security and liability, not only in the jail system, following diversion anywhere, plus also danger to office staff and patients, other patients. It is very real. I have experienced it, but it's recognizable, and but people do have to understand that that is one of the reasons people are not going into this field. The costs of MAT, the reimbursements are not there yet. Personal beliefs and stigma. Many people in authority believe that if you break the law, you go to jail. So the concept of changing the personal beliefs and stigma, we don't send people with diabetes to jail if they don't take their insulin, but yet we do treat addiction differently. Next slide. You got to have a committed team to succeed. What we really want to do is stem the cycle of arrest, incarceration, followed by arrest, incarceration, followed by arrest and incarceration. In order to do that, we're going to have to build a committed team in every jail system in every county in Michigan. You'll need to have a sheriff that understands and accepts MAT and recovery programming in general. You'll have to have a jail administrator. You'll have to have the jail medical, the jail staff, counselors, the providers. You'll have to have continuity out into the community for continuity of care, that warm handoff once they get out of jail. And also psychiatrists. It's we're talking about treating a medical disease of addiction, but if we're not treating their other mental health illnesses at the same time, there's a very low chance of success. So you've got to have a full team plus case managers, any kind of CMH support, people for housing, financing, getting Medicaid turned on and off, getting transportation, and now during the pandemic, any other medical care that they need. So it's going to take the whole village in order for this to be successful. Next slide, please. Promising practices. You can read these. Most of them are pretty common sense. Next slide, please. Societal benefits of MAT. Obviously, and again, these are common sense. It decreases the rate of recidivism, decreases harm to families, and allows them to rebuild in a healthy manner. Decreases overdose deaths. And again, to reiterate, that 2-week period after discharge into the community, overdose death rates during that time is the #1 cause of death of those released. It decreases the spread of infectious disease, meaning HIV, hepatitis, and actually STDs. It decreases crime in the community and decreases the cost burden. It costs around $25,000 a year in one county jail to house an inmate versus $4,000 for MAT treatment. Next slide, please. Preventing misuse. These are just some tips that we've seen work very well in the jail system for administering buprenorphine, is to do it with observed drug administration. And then give the medication to the client, observe them for 15 minutes to a half hour afterwards, do an oral inspection by having them open their mouth, move their tongue side to side. You may use a tongue depressor to ensure that the medication has been ingested. Keep their hands down away from their mouth, and then you can also do the swish and swallow with a small amount of water. monitoring medication levels versus random UDS. And that should be, it's a tool that's very helpful. It's on-site testing with someone giving a urine sample into a cup, and you can see within 5 minutes what medications are actually in their body. And I'm surprised jails aren't using this more often, just to monitor for other drug diversion among all inmates. Be vigilant. There's a certain pattern of behavior when people are misusing medications, and that goes for all medications, not just buprenorphine, and report it so that patterns can be recognized in specific jails. And don't expect perfection. The criminogenic thinking can be very clever, and I've had a couple of them where over time I've learned a lot how they're thinking, how to avoid following the rules and continue to divert. So things are going to happen. There's going to be bad outcomes, and those need to be discussed in a healthy manner in order to learn from them going forward. Next slide, please. This is another landmark paper. It's from the NDCI, the National Drug Court Institute. Medication-assisted treatment for opioid use disorders in drug courts. And it's authored by Benjamin Nordstrom and Douglas Marlowe, who are two preeminent authors. And this is a landmark paper in which they say non-medically trained criminal justice professionals should never make medical decisions regarding MAT. So with people like the sheriffs, like the judges, like the prosecutors, like POs, the medical decision making should be made by the medical providers, medically trained experts, in conjunction with the court and jail teams. So it's not just one or the other. Both the criminal justice system and the physicians or providers need to be able to find a common ground to communicate in order to create successful programs individualized for each patient. It's not just one size fits all. Next slide, please. So addressing the challenges, next slide. Again, these are very common sense, but worthwhile discussion points to consider when you are implementing MAT in order to see some of the obstacles that are preventing successful implementation and to create conversations so that you can overcome those obstacles. One very common program right now is to consider changing the language and not, for example, not calling people with addiction addicts, but to call them people with addiction. To show a more empathetic understanding of addiction as a medical disease rather than as a choice. Teaching the disease model not only for addiction, but also about MAT. Again, follow the science. It's not magic. It's not created out of the clear blue. It's evidence-based science. And reviewing the low treatment success rates without MAT. Next slide, please. Safety threats, both in the jail and in any others, like an office situation. Provide staff training, keeping current, know your standards for securely storing medications. We conduct pill and film counts randomly. You wouldn't be doing that in the jail, but some of the POs and the peripheral, as they transition from throughout the criminal justice system, pill and film counts become very valuable for keeping track of how they're taking their medication. Next slide, please. Advancing staff training, working with your providers in the, not only in the jail, but in the field. Get peer mentoring, people that are already experienced with this population can help train new people that are interested in it. So establishing peer mentoring with your staff, hooking up with another jail that has experience. And that would be sheriff to sheriff, jail administration to jail administration, jail medical to jail medical, counseling to counseling. And those resources are available. They're becoming more widely available. Obviously, this group has some critical expertise that can be taken advantage of. And then appoint change agents, people that know what needs to be done and then kind of follow their lead. Next slide, please. Funding, it's always been a problem. There's more and more grants available. The state is opening up more. There's the older block grants. You can get creative. Many community agencies have large philanthropic grant funding agencies. County commission, because the jails are county-based, it's worthwhile to seek more funding from county commissions through their annual budget process. And remember, once people are incarcerated in Michigan, they lose their Medicaid while they're incarcerated. So Medicaid does not cover, and there are some jail variability with that, but Medicaid does not cover MAT in the jails at this point. And then obviously case managers for discharge planning. So when they are discharged, they have their MAT already funded and in place for continuity. Next slide, please. Establishing MAT providers. So partner with your people in the community. Get a provider that's experienced and comfortable with dealing with this population in your jail. Muskegon has a nice program with doing that so that there will be continuity out in the community once they're discharged. And offer them licensing and training for your corporate providers. Next slide. Building partnerships. This population tends to violate multi-jurisdictionally. They will cross county lines. I've had several patients in 3 different court systems in 3 different counties, bouncing in and out of jail. One county had MAT, one didn't. And when for example, when they went back and forth, the Suboxone would be allowed and then it would be discontinued. They would go into withdrawal during that first week after discontinuing. Then they'd wind up going back to another program that offered it. So this very limited regional, we need to have a fully regional similar approach to prevent that. If they are on MAT, it should be continued at all costs, no matter what it takes. And that needs to be a statewide program eventually so that all drug courts, all jails, all facets for people that are not that are in the criminal justice system but not in specialty courts or the jail, all of that needs to be provided at a similar level to prevent this on off, because that is not going to be helpful in creating a good, healthy recovery program. And to build a network of existing resources and services for the client. One of the common excuses I've had to deal with is, well, we can't start them on buprenorphine in drug treatment court or even in the jail because the sober living that they're going to doesn't allow it. And I've changed it. Over the past 3 to 4 years, we've started the MAT for the patient and done the right medical treatment for that client. And then it's up to the community to build their own support system and resources to support that patient on MAT. It's not appropriate to withhold MAT just because the next transition that the patient goes to does not offer it. That is not appropriate. It needs to change, and I was able to create change with several residential programs several years ago by working with them individually, teaching them, showing them one client at a time how it works. And now it's an open system for those areas in the mid-Michigan area where I've been working. So, but it did take work. It did take communication. It took one-on-one personal involvement from me as a provider in order to build trust for building those resources. Next slide, please. Psychosocial needs at discharge. Obviously, this is another clinical common sense one. Enroll the patient in wraparound services. Make sure they're activated and ready to go at discharge. Next slide, please. Identifying MAT eligible clients through your jail entry surveys, and then as appropriate, educating them about MAT, offering them services, and then obviously naloxone. Next slide. Thank you all for listening, and we'll see how the questions come in. I'll turn it back to Matt.
Thank you, Doctor. I appreciate that very much. And as a reminder, for those who have questions, please just type them in the Q&A box here, and we'll get to them in the order with which we receive them. If we're not able to get to them all, the center will put a listing of all the questions and responses to that. So without further ado, I'll start with our questions right from the beginning. And the first question is for buprenorphine, is there a different absorption rate when the pill is crushed versus the strip form?
That's an interesting question. I don't know a scientific answer for it, but it should not make a difference. By putting them underneath the tongue, both of them are absorbed over a period of 5, 10, 15 minutes.
Thank you. The next is less about a question here, and it's more of a clarification about the waiver system. It did not occur. It was proposed to the former president in the last days, but was not submitted properly. It looks like it's still kind of being worked on there. So in the Q&A box is the information from the sources for that information, but that hasn't gone into effect quite yet. So just more of a clarification than a question. So go from there. The next question is any suggestions for bridging the insurance before people get out of jail? It's our understanding that people are ineligible to restart Medicaid while they're incarcerated. How can we help people feel supported in their ability to pay immediately after release? Before I turn that over to you, Dr. Tu, one of the things that the center came across is the reintroduction of legislation for these services, for these benefits to be started 30 days prior to the jail release. Not necessarily, I don't think, for them to be paid for services while still in the jail. So, but when they walk out minute one, that those benefits are activated. So there is discussion that seems to be going on. It has some bipartisan support, but again, it's still in the deliberation stages for acceptance. But Doctor, I'm not sure if you have anything to add to that or know more about it than I might have talked about.
I don't know more about funding while they're in jail more than what you said, but the important thing is to prepare for discharge planning. The system that works best is to have your discharge planning case manager start ahead of time so that the day that that person walks out of the jail, that their Medicaid is activated. And that is a critical process. It is people assume that, yeah, I made the phone call, I left the message and told them they were being discharged, but we're seeing commonly that it doesn't happen, and it's requiring up to 2 weeks for the client to contact their Medicaid caseworker after discharge in order to get it activated. So that point of pre-planning, so it's personally communicated to the Medicaid caseworker, and then prior to discharge, and then having the client at discharge immediately call to start working on getting it activated. In some programs, it seems to go without a hitch. In other programs, it's a major stumbling block.
Yeah, and it seems like in our OTE communities, the 5 that we're working now, the CBHJ is working with, when there's that direct relationship between the sheriff's office and the MDHHS staff involved with this process, we have a lot better luck for those benefits to at least be ready to be reactivated upon discharge. But again, your points are well made, Doctor. I'll go to the next, again, another comment here. The DSM-5, the term addictions is obsolete. So that's just a clarification on terminology that was being used. The last question here I see, if I'm again just reading it for the first time, so I apologize for that. This slide that talked about checking drug levels with urine testing. If you're using observed dosing, how would this testing change your treatment plan of the incarcerated individual? The urine test is very significant disincentive to participate in MAT. Would you change treatment with buprenorphine if you found out someone was using another substance?
So if I understand the question correctly, we're talking about urine drug testing in a jail with a patient on buprenorphine. Is that correct?
Yeah, I can reread it. It's a multiple part. Why don't I start over? Your slide talking about drug levels with urine testing. If you're using observed dosing, how would this testing change your treatment plan of an incarcerated individual?
So in doing urine testing, basically you're confirming drug ingestion and confirming use or non-use of other medications. With a patient that you're giving observed buprenorphine in a jail, they may still be getting other drugs from other inmates. That's well known. So you want to screen them for other drugs as well, but you also want to ensure that they're ingesting the buprenorphine and not diverting it in any manner, no matter if it's observed. Even the observed administration is not perfect. So all you're doing is confirming what you're hoping is an adequate treatment. I'm a proponent of screening patients regularly, whether or not in the jail or on the outside, because it's one of the few objective tools you have for confirming their history. This can be a very devious and clever population, and the value of a drug screen can help confirm that you're dosing buprenorphine adequately, and that they're actually getting it and not diverting it.
Drug testing, whether you're community-based or jail-based, isn't that a requirement of MAT programming?
It is in an appropriate sense. There's no standards for doing it because it can be very complicated to interpret the drug levels. When you do the on-site testing, it screens for 5, 6, 7 medication classes, but it's only a screen, and there can be a significant percentage of errors in positive and negative readings. So confirming it with a commercial lab evaluation, which can measure hundreds of medications, and actually measure its specific levels is the confirmatory is the more believable and trusted. It's the gold standard for interpreting urine drug testing.
Maybe the last question here, Doctor. Can you talk about what is the process typically involved in starting with Sublocade? You can't really just start somebody right from the get-go. Isn't there? What is the process for starting somebody on Sublocade?
So Sublocade is the 28-day injectable form of Suboxone. It has both buprenorphine and naloxone in it. In order to assess a patient to start on Sublocade, they would need to show that their body was able to tolerate the Suboxone drugs. So you would need to start them at least on a 1-week trial of the oral or sublingual Suboxone first to establish that they're not going to go into precipitated withdrawal, that they won't have any other adverse reactions. So a week trial on the sublingual form is the standard, and then going to the injection if tolerated.
Okay. And then transitioning back into the community, if you're going to come off the Sublocade, would it be, how do you manage that? So if I'm getting it inside the jail and I'm going to a community provider that doesn't necessarily provide it, what is there a process for offboarding from Sublocade?
Well, remember, Sublocade is Suboxone, so you would just restart the oral form.
Okay.
After the injection at around the 28-day mark, or when people start to feel the cravings, then you just start the oral form again and adjust the dosage accordingly over time. Traditionally, we see with Sublocade that it tends to wear off a couple of days early. Again, every patient metabolizes it a little differently. So again, it's a one-on-one management to see how they do. You have to start somewhere and then see how they do with it. But no, it's the same medication. It's just 2 different formulations for administration. So no problems there at all.
Perfect. Thank you. That's it for the Q&A portion of our presentation. I'm going to turn it back over to Becca for our closing remarks. And again, thank you, Doctor. I really appreciate your time and expertise this morning.
Thank you, Dr. Kapenga, and thank you to everyone who joined us here today for this OTE Community of Practice Lunch and Learn. A recording of this webinar will be posted on the CBHJ website and YouTube page within the next week or so. And we will also send a copy of the slides and all related materials to every attendee as soon as we can. Please keep an eye out for future events in this series. These webinars will be held every other month, with the next one to be scheduled in April. Last but certainly not least, it's important to us that the content we share is useful and relevant to the work that you're doing, and we value any feedback you have. We would appreciate you taking a moment as this webinar ends by clicking the link that pops up on your screen to complete a very brief survey. Thanks again for joining us today, and we'll talk to you all soon.